I'm going to talk to you about FFRCT and coronary disease. This is a topic that is growing, and the wealth of knowledge about this is growing every year. I'll review with you some of the data that is available. Some of it is actually just published yesterday. So what do we know about the current status of coronary disease diagnosis? There are some papers that address this topic. Some of the landmark paper came from the NCDR registry in the US, which clearly shows that a lot of patients who go to the cath lab, apparently even with a positive stress test, have no obstructive coronary disease. This is data from multiple centers in the US, and 2/3 of the patients who go to the cath lab after a stress test end up having normal coronaries or non-obstructive disease. This is data that we put together from the state of Michigan registry, published in JACC a couple years ago, where we show that only 24% of all non-invasive tests predicts the presence of coronary disease. This is real-life data. This is consecutive patients who went in there and had their cath or CTA after. And 80% of those with positive non-invasive tests in reality have no obstructive disease. This is data. We did not cherry-pick patients. These are patients who ended up in CTA or cath after a non-invasive test. So I'm not here to preach to you CTA. We all know that we can get very nice images and very pretty images, and excellent assessment of the coronaries by coronary CT angiography can be done with very low radiation, but it's not always the case like this. We don't always get this kind of anatomy and good pictures. Sometimes we get up something like this. And you can see I'm losing my hair every year I come here, because when I get these cases, I start pulling my hair. What happens? Is this 0 to 24, 24 to 49? What shall I call it? And I'll take more pictures. I look at it more. What do I call lumen? What do I call it? Like positive remodeling? What type of plaque? And this is what limits cardiac CT. It's the positive predictive value. And this is even at a per vessel or per patient analysis. You can see that when we have this diagnosis with this type of plaques, we're almost flipping a coin. You can take my opinion, you can flip the coin, you'll probably get the same result in there. So what do we do with these patients? Now, the bottom line is we have two ways to diagnose coronary disease. We can look for functional and we can look for anatomy. Functional can be done by non-invasive testing, and anatomy so far non-invasively is only coronary CT angiography. If we're going to go the route of invasive, we have obviously different ways to look at it in anatomy, and obviously now FFR is invasive. FFR has been well documented to impact on the patient's outcome. But if we're going to look non-invasive, we have a non-invasive tool which is coronary CT. But if you're going to look at function, you have the whole wealth of functional testing, which I already told you has not been performing very well in the community. It may have performed very well in randomized controlled trials or in excellent centers, but when we put it out in the community, it's not performing as well. So how can we do it? Well, if we take our non-invasive anatomy and invasive FFR, we don't correlate very well. We have 75% false positives between CTA and invasive FFR. So whatever I call obstructive disease, when you go into cath lab and do FFR for them, invasive FFR, you're getting me wrong 75% of the time. What about non-invasive physiology? Between CT and ischemia, flipping a coin, 50%. So 50% of those who have a positive CTA have only ischemia. So which one we're going to look at? We're going to look at ischemia, or we're going to look at anatomy and treat patients accordingly? Well, the data is clear. This is data from the interventional world, which clearly tells you that FFR is now the gold standard to determine the optimal artery-specific therapy, whether medical or PCI. And if you look in here, it results in 33% reduction in the risk of death or MI or cardiovascular events from the FAME data. So can we get something like this as non-invasive? And this is where it all started. This is a company that is in Silicon Valley in California, I have no association with this company. I'm not trying to sell you anything here. It's called HeartFlow. It's actually founded by two professors from Stanford who has been spending long time doing this kind of analysis. They have expertise in software development, and they came up with this CT FFR tool, which now, as of today, I got this slide from them. They told me that now it's approved to be sold in Europe, Russia, Japan, Australia. In the US, it's still pending 510 FDA. So how does it work? I do a CT, I find a lesion, I'm not sure, I cannot make up my mind. Right now, the only way to do it is that I have to send them my DICOM images. So for those of us who do imaging, we have to get the DICOM images, put it either on Dropbox or do any tool or put it on a DVT, ship it to Stanford, ship it to Silicon Valley. They will put it on their supercomputers, run it for about 24 to 48 hours, and then they will send you a report which tells you what's the FFR for this. So they're going to use a lot of high technology which will come up with this evaluation. So this one, obviously, I'm going to ask everybody to memorize these formulas that they use, looking at hemodynamic assessment that they do, which is mostly looking at actually aerodynamics and the fluid dynamics through the vessel. Again, don't ask me how they do it. Took them 30 years to come up with this kind of methodology, but after all, once you send them the data, they're going to come and tell you, okay, this is what we think the FFR in this vessel, this is what we think the FFR in this vessel. And these are some cases. So you can see in here some of a patient who has an LAD lesion, and by invasive FFR down the LAD it was 0.74, and by their computed method it came out to be 0.7. This is a patient who has a lesion. We're not sure. There is calcification. It's not very clear. Even on angiography, it looks like a little bit it's tight, but by invasive FFR, it was 0.89, and they got it right by CT FFR. They come up with 0.88. This is, for example, another patient who has multiple FFRs that are positive, which clearly correlated very well with the invasive assessment. You can even come up with something called like a virtual FFR after you do your PCR. This is a paper published in JACC Intervention last year, where they can tell you that there are sequential lesions in here. So do I need to stent all the 3 lesions, or do I need to stent just 1 lesion? So they will tell you if you stent 1 lesion, the CT FFR is going to be 0.72. You stent both lesions, now you're going to come up with an FFR of 0.86. So this will be helpful in patients who have tandem lesions and you want to make up your mind which one to stent, or you need to do all of them. And this is where it could potentially be helpful. So what about the clinical data to support this? I'm not just showing you numbers that correlate, but in reality it does not all the time. Well, the 3 landmark studies, all of them published in highly cited journals. You can see Discover Flow was the first study, included 104 patients, mostly from Asia. The de facto trial, published in JAMA, looked at 252 patients, mostly US sites. And the NXT trial, it completed in 2013, also published in JACC a few months ago, which also looked at nearly 254 patients. But publications on CT FFR, you can see as of today, there are 39 publications on this topic. Sorry, they are listed here. And you can see the wealth of information about this topic is now growing significantly. I'll show you data from one of those studies. In blue, you see the diagnostic accuracy of CT alone. And if in red, you see here the diagnostic accuracy of CT FFR in comparison to FFR. So now I'm not comparing to just QCA and cath. I'm comparing to invasive FFR. Every time they see a lesion, these patients, when they went to the cath lab, they did FFR. So CT accuracy, just CT accuracy compared to FFR, as we knew from before, not too good. Our specificity is actually the worst, and the positive predictive value. But you can see with CT FFR, all of these went up with little or no change in sensitivity and negative predictive value. This is per vessel, and this is compared to invasive angiography. Now we can see in here that FFR CT is almost equal or even better than just invasive angiography without hemodynamic assessment, just looking at eyeballing by invasive angiography. And the most important thing here is that really FFRCT reclassified 68% who were called before false positives as true negative. So these are patients that would have gone to cath, but these are patients who would have gone to have other resource utilization, stress testing, and other things which when they really do not need it. What is also important is that it works across the range of calcium score. Here you see the accuracy divided by calcium score, and irrespective of what's the calcium score, you can see there is significant improvement in FFRCT in terms of specificity in this trial. So now if we plot the sensitivity and specificity of all the different non-invasive tools, you can see FFRCT has the best profile compared to all other modalities in terms of MR and stress testing and nuclear stress testing in there. There is also some modeling data that was just published from Malk Harty from Stanford, also looking at the potential cost saving if we adopt this approach. And he estimated that in the US market we can potentially save about $3,100 overall if you end up using FFRCT in these patients with intermediate lesions. So there is more data to come. I just showed you a snapshot of the data, but there is more data to come about FFRCT. The platform trial is just finished actually, and this is the steering committee, Pam Douglas, Gianluca Pontoni from Italy, and this is looking at the impact on resource utilization. So we know it's accurate. Does it really impact on resource utilization? And the main aim of this study, which is, I'm not going to go over this because it's still complicated, but to simplify, they're looking at the percentage of negative invasive angiography performed. They want to see if you're using CT and FFR, are you lowering your rate of normal cath or patients with non-obstructive disease that you would not have cath otherwise in these patients. This is some cases from this registry given to me by Gianluca Pontoni, where you can see in here a patient who has this calcification in the left main. It looks like some blooming, sorry, in the LAD, there is some blooming in there, and when they did FFR, it was FFRCT, it was 0.88. This patient did not go for any further workup, and they stopped in there. This is a patient, another one, who actually has a lesion, looks intermediate. I see lumen, but there's also negative remodeling and plaque. And you can see in RCA when they did FFRCT, they found out it is 0.77. So this is the patient that you would send for cardiac catheterization and intervention. And this patient, when he went to the cath lab, they come up with an FFRCT of 0.76. So now the biggest concern about this tool actually is mainly the logistics actually, because now what I need to do is to take my data, and somebody could argue because there is a cost for that, and the cost could be about $1,500 extra just to do the processing. So which one? If I have a cath lab next to me, am I going to wait 1 week for this result to come? Why don't I just go stick in a needle in the groin and do two shots and call it a day? So maybe I'm not going to think the same if I'm able to do FFRCT on my own workstation. So if I have my CT machine able to do it at my site, and I have enough cases, I don't need to pay per every case, then it might be more useful. And this is where people are now searching. And this paper just published yesterday on radiology, coming up from a different company. It's not heart flow anymore, looking at fractional flow reserve computed from non-invasive CT on-site clinician-operated computational fluid dynamics algorithm. So this now is done on the machine itself. So what you do, now this is not the same as what I told you before, because the heart flow is actually using 3D finite element model, while the one that is computed with the computer that you have on your CT machine or your workstation is going to be a 1D model. So the 1D model versus 3D model, obviously I'm not again a physicist or expert on this, but I can tell you that there are some differences in there, and these differences we have to see how do they play out in terms of the practicality and the accuracy of this data. Again, this is the first report on a 1D model, and you can see in here that they are not exactly the same. So in the 1D model we only take cross-sectional areas. 3D model take the entire vessel boundaries, and you can compute it efficiently. You can come up, you cannot do bifurcation and model branches in the 1D versus you can do it with the 3D. So there are some differences, and we have to wait and see if these differences are really going to be important in the real life clinical practice. But this is the data that comes in from 108 patients, about 180 vessels of these patients, and you can see most of them actually had intermediate lesions. So the data that you will see in here is not really representative of the diagnostic accuracy of cardiac CT. It's more representative of the diagnostic accuracy of intermediate lesions, which is about 76% in this study. And these are some of the examples that come from an on-site model. This is the software, again, still being developed. And where you can see in here a patient who has a lesion in there, and this patient has an invasive FFR, which is significant, and turned out, non-invasive was significant and confirmed invasively. And this is another case, which is, again, published in radiology, which appears to be, there's a lesion in there. It was not significant by invasive FFR, and it was not significant by invasive and non-invasive FFR. So how does accuracy look in here? And here we are comparing CT versus CT FFR, when we are seeing almost the same, similar results. So we see that specificity increased significantly, but somebody could argue that we are not there yet, because still a specificity of 59% I'm not too happy with, but sensitivity is still again 87%. The negative predictive value went up to 85%, and the accuracy overall went up to 71%. And if you compare it to cath QCA like they did in the NXT, you can see in here in red it is the cath, and at least it is as good as the cath data just by QCA, not using the invasive FFR. And this is by
3 minutes, Dr.
and by AUC. If I look by AUC in here, the area under the curve, they were similar in there. So the problem was actually when they compared the non-invasive versus invasive FFR, the correlation was only 0.59. So it's still on the lower end. We would like to see better correlation. And I know that at least there are 10 groups worldwide that are working on local CT FFR development. We will see how efficient these are going to be and what's their data with that. And the blend ultimate clearly shows that it is between minus 0.31 and 0.22, which is again not going to be extremely helpful in that setting if we're going to run into this kind of range. We would like these to be much less in terms of blend ultimate limits. So skip this slide and come to my conclusion slide, which clearly I've shown you that with FFR CT we're better than CT, but we still probably need a little bit more to push it. So we improved our accuracy over CT for diagnosis of patients and vessels with ischemia. It's clearly superior to CT for intermediate stenosis, and it can be done without additional radiation, but with additional cost. We have to play all of it to figure out how is it going to be helpful eventually in the workup of our patients. Thank you very much for your attention.